today we are going to cover just some quick PYQs, previous year questions on INICET is your upcoming exam, and thought it would make sense to just do a quick recap, and if you have any doubts, of course, clarify those. ENT questions are fairly simple, though ENT comes in a very integrated fashion, very clinical questions that are coming, but it's good to know some of the basic questions. So if you have any doubts, please put it up in the chat window. I am here. Right. Okay. Great. It's showing live. Okay, guys. So let me do some questions that were done, that were asked just in your last previous previous year's questions. So your first question that was asked, I think your last INICET there were only about 5 or 6 questions पूछे गए थे, and काफी simple straightforward questions पूछे गए थे. So like this one is, name the nerve block in this procedure. Okay, so there's only 2 options which appear कि इनमें से कोई हो सकता है, otherwise see the sphenopalatine and the Vidian are largely deep in the nasal cavity. Okay, for surface blocks your only options are nasociliary and anterior ethmoidal. This nasociliary nerve block, the reason why it is done is because it's a OPD procedure and it's a block to treat certain types of headaches. Now nasociliary nerve is a branch of the inferior trochlear nerve, and this sometimes causes headaches, and to reduce this headaches is when they give this as a small OPD procedure where you can cause this nasociliary block. Anterior ethmoidal nerve block is usually given here on the dorsum of the nose, at this part where you would give it, and that is usually done to numb the septum, and sometimes useful for septal surgeries. So here the correct option will be option A, nasociliary nerve block in this procedure, as going by the location here. The nerve is there. All right. Okay. Match the following just like we were trained in our school days. Very simple. Match the following. INICET level में ये question पिछली बार पूछा गया था in regards to thyroid swelling obstruction. Okay, so basically it is asking, on the left side there are certain structures, and the right side there are certain symptoms. Match. So if the thyroid obstructs the trachea, then what is going to be the symptom? That is what they are trying to mean. So here, if the trachea is obstructed, of course you're going to have dyspnea. So to save time, generally in these exams, just look at which options are giving you the starting answer, right? Abhi isme there were 4 options are there. You can see A4 is there only in these 2 options, C and D, so you don't waste time on options A and B. Agar esophagus is blocked by the obstructed by the thyroid gland, then obviously it's going to cause dysphagia. Okay, it's supposed to be dysphagia. Dysphagia is another way of saying that you cannot speak very well. So that is going to be B1. So automatically C becomes the right option. You don't have to waste your time in the other 2. However, recurrent laryngeal nerve is going to cause hoarseness of voice, and sympathetic chain is going to cause Horner syndrome. Now arrange the order of Bera. Now this is one question, guys. ये कम से कम INICET या NEET PG या FMG, anything you take, this question of the pathway of the auditory nerve is always asked. Examiners को लगता है कि ये डालेंगे तो confusing है, because you can't make head and tail of these names, what the meanings of these mean. So people are bound to get confused, and that's why this is asked a lot. They're basically asking that in the auditory pathway, what is from the cochlea all the way to the brain, what is the pathway that is being followed? Okay, so let's go by this one by one. Now so these are basically right, so they're basically asking what is the sequence. So obviously it has to start from the spiral ganglion and the cochlea. So right, so 1 and 2, so AB has to be first. AB here, if you look at it, only one option is giving AB, so obviously that is going to be the correct one. And if you look at it, इन लोगों ने order भी correctly दिया है, superior olivary nucleus, then lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. इसको कैसे याद करते हैं? There is a logical way to learn it and there is an illogical way to learn it. Now the logical way to learn it is basically this auditory nerves, this pathway is going from the medulla to the pons to the midbrain, right, and that to the auditory cortex. All right, so that is the pathway that it is taking. So you need to know what is in the medulla, what is in the pons, and what is in the midbrain. So the cochlear nucleus, the spiral ganglion, is in the house in the cochlea, right, in the inside the the auditory system of the cochlea, and the cochlear nucleus is in the medulla. So there is no confusion there. Cochlea se start hota hai, cochlear nucleus. The problem comes next. What is there in the pons? How do you identify it from these four? Now, olives or olivary structures, if you look at the structure of the pons, it has these kind of rays, these kind of reticulate fibers, and they're little olive like circular things. So generally olive or olivary word comes from the description of pons. So superior olivary nucleus is above, and then those little reticulate bands that come, they are the lateral lemniscus that go laterally. When you look at the pons, these lateral these kind of bands, they are the lateral lemnisci. So it's just the people who did anatomy are just describing it in the Greek and Latin that they knew. Looks like एक olive is the upper part and then these bands go laterally. So that's how they are pons. Superior olivary nucleus is superior, it comes first, and then the lateral part comes after that. That is the nomenclature way to remember it. The illogical way to remember it is, if you look at the word superior olivary nucleus, इसमें PONS pons word बनता है. That's how I used to remember. But sometimes instead of superior olivary nucleus, they give superior olivary complex, and then the situation becomes very complex because वहाँ pons नहीं बनता है. But lateral lemniscus, having said, is lateral fibers, so that's always going to come after. Colliculus is basically, in once the brain starts, you start having this little cauliflower like these appearances, and the colliculus comes from the cauliflower or the rounded appearances. So that comes in the midbrain, and then the medial genuculate body. Genu always means a turn, so that means it's turning inside towards the auditory cortex, and that's why the turn is always going to be before the destination. You say आगे से dead end से right लो, right lete या left lete, you reach your location. So the genu or the turn is normally before the location. So with that, maybe a little bit of the nomenclature, and that you don't have to really by heart this. You can try and remember this pathway. ये 100% आता ही है किसी न किसी तरीके से. This is what they feel is complex in ENT at your level. All right. So here's the pathway again. After the cochlear nucleus, the superior olivary nucleus, the lateral lemniscus, inferior colliculus, medial geniculate body, and the auditory cortex. All right. So that would be option A here. Okay. Now, an elderly man comes to polyp hanging from the nose and he takes a bath in the pond regularly. दो sentence का question है, and bath has got equal importance to polyp. Why is this information there? And that's the beauty of these MCQs, that the examiner has to give you hints. Otherwise, in medicine, कुछ भी हो सकता है. But when they give you certain hints, that makes the diagnosis more likely, so that they can justify that this answer is correct. The significance of bathing in ponds and stagnating water is where Rhinosporidium seaveri is there, and that causes rhinosporidiosis, which gives this characteristic strawberry-like appearance into the nose. And whenever there is any pond bathing that occurs, they are invariably pointing towards rhinosporidiosis. It's an image-based spot diagnosis question. Now, what is the likely diagnosis in the image below? Now, all of these four sound a bit similar. Ranula and mucocele में confusion होता है. Normally, whether it is ranula or mucocele, I'm going to tell you in a simple way how to differentiate these two. Ludwig's angina is the floor of the tongue, base of the tongue का cellulitis, hardening, goody like strong over here, and infection and all of that. That is Ludwig's angina. Dermoid cyst is a cystic swelling that occurs at the point of fusion of bones. Usually when two joints of the skull bones are meeting, usually over here, wherever it is, where the two bones are fusing, there is where the dermoid cyst comes from. You won't get dermoid cyst in this soft tissue over here. Now, mucocele and ranula, what is the difference? See, ranula comes from the word rana. Rana means frog. In Latin, the underbelly of the frog. मेढ़क को उठा के ऊपर रख के नीचे से देखोगे ranula दिखेगा. and that is how the description was from the people who named it. So it is the appearance of the belly of the frog in the floor or the base of the tongue or the floor of the mouth. So ranula is a location based name that is given, which is floor of mouth. Okay, if there is a large swelling on your lower lip or upper lip, that is not going to be a ranula. Ranula basically is a large mucocele itself. Could be an extravasation type, could be a retention type. It is arising from one of the major salivary glands, submandibular or sublingual salivary glands. It appears bluish because there is some congestion, and because of that there's a bit of cyanotic bluish discoloration of the vessels over there, and that's why ranula is a floor of the mouth location. You see it here, this is the frenulum, and on the either side of the frenulum, any one place, you see this large belly of the frog like appearance. That is a ranula. Mucoceles, usually after a history of trauma, they are small. They're not usually necessarily from the major salivary glands. They could be somewhere in the base, lower lip, somewhere in those kind of places. You can have a small mucocele even here and there, but mucoceles are usually small, and they are not really the floor of the mouth ones. But large floor of the mouth occupying belly of the frog looking appearance is what would be a ranula. In this case, it is a ranula. Okay. Now, a 14-year-old female presents to the ENT OPD, complains that she can understand the language, hear the sound, but able to understand the meaning. I'm sure a lot of you find this in of the classes of medicine. Your language समझ में आता है, सर हिंदी बोल दो, इंग्लिश बोल दो, कुछ भी बोल दो, language समझ में आ रहा है, but you're not able to hear the sound also. A lot of noise is coming repetitively, but you're not able to comprehend. Not able to comprehend means you're not able to process that information का meaning क्या है, not able to understand that. So the pure tone audiometry, which is a subjective hearing test, and the auditory brainstem response, also BERA, is normal, which basically means the hearing mechanism all the way till the auditory cortex is normal. Now, what is this? Why is this girl not able to understand? What is wrong over here? Now, because malingering is basically, trying to falsely show some symptoms so that you get some sort of a financial gain, like certificate or some extra privilege of that disability that one will get. All right, here nothing in this description tells us why would this girl want to linger. So unlikely option. Now, Wernicke's aphasia, auditory neuropathy, you have the comprehension issue. You can listen, you can hear the sound, you can understand the language, you can recognize the language, but you cannot understand the meaning of the words. So, Wernicke's or auditory neuropathy is the condition that is being here. Otosclerosis would show conductive hearing loss. Michel's aplasia would be, not being able to hear anything at all. So again, both of them would show in the pure tone audiometry or the APR. But Wernicke's aphasia, your hearing is completely normal. Comprehension, guys, check yourself. Wernicke's aphasia or Wernicke's aphasia, auditory neuropathy, right? So now these are the questions that were asked in your last INICET exam. Let's see what has been asked, or the trend that has been asked in older PYQs from 2022 to 2020. Okay, now radiological image-based questions have become a new trend, especially in INICET, also in NEET PG and MG. So they want more clinical exposure in students and all of that. So here you can see this is an axial section of a CT scan. Okay, how do I know it's a CT scan or not an MRI? Because the CT scan, you see this kind of white, which is bone, and this grayish color is soft tissue. There are three basic sections. One is a coronal section, which is agar main aisa cut ke, the way I'm looking at you, that is a coronal section. This is the sagittal section, if it cut sideways like this, and axial section is like this, which I think Viva mein tumhare sath hone wala hai, axial section. So this is an axial cut at the level of the thyroid cartilage. We can see that over here, the thyroid cartilage, and they're asking what is the stage of the laryngeal carcinoma over here. Now there is no lymph nodes basically seen. You can just see that the both structures are symmetric on sides. So basically the funda of TNM staging of cancer larynx is based on mobility of the vocal cords and whether it is within the larynx or it is extra laryngeal. Now T1, T2, yeah, usually there will be mobile vocal cords, either one mobile or both mobile vocal cords, and there is some no fixation. But the moment T3 comes, there will be fixation and spread to more than one or two sites or subsites of the larynx. Here you can see that this whole laryngeal cancer has actually come out through the thyroid cartilage outside anteriorly. That's why this is a very straightforward T4A. T4B hota, then there would be prevertebral, paravertebral spread posteriorly, which is also another extra laryngeal location. So T4A, N1, M0 would be the thing. I think the node that they're talking about over here is I think this lymph node that is seen. Okay, so that's the nodal area. I cannot make out very clearly with this blurry image, but because of the extension outside, T4A is the option. Now given alongside is an image of the tympanic membrane with a retraction pocket. Okay, this is the pars flaccida, this is the pars tensa. This area here is retracted, andar dhasa hua hai, it is pulled inside. So what is the grade of the retraction pocket? Now there is 1, 2, 3, 4, 5 grading of the pars flaccida. There is 1, 2, 3, 4 grading of the pars tensa when it comes to retraction. Now if an air pocket is there, pars flaccida, pars tensa. All right. So in pars flaccida, 1, 2, 3, 4, 5. Now if there is an air pocket that is seen, then with the retraction, then that is 1. If there is no air pocket, then that's 2. Third one is if it is fully adherent, it is stuck to the malleus inside, it's stuck inside, so it's adherent, then that would be 3. 4 would be some erosion being seen. You can see some bony erosion over here. This is most likely going to be grade 4 in the retraction pocket. If you see some cholesteatoma, then that is grade 5. Okay, so this is how the grading is done. In the pars tensa, there is again 1, 2, 3, 4 grading. This is very simple. Cone of light will be absent, grade 1. Prominent, your malleus, your short process of the malleus. Okay, and the malleus will appear foreshortened. Normally malleus will be a little longer, but it will appear shorter because it is pulled inside. That is what you will see in cone of light absent, and second one you will see more prominent malleus. And grade 3 and grade 4, one is adhesive, the one is atelectatic. What does that mean? One is adhesive, means okay, it is plastered. You can see the promontory, it's gone all the way to the back. But if you do sigillization, if you're going to put in some air inside, then the tympanic membrane is going to not be adhesive, it come out. But atelectic matlab kitna bhi you try to give air inside through the eustachian tube, you try to do sigillization, the tympanic membrane is plastered onto the promontory. It's grade 4 severe retraction, right? Now, patient presented to the emergency with acute vertigo with horizontal nystagmus, slow component towards left side. What is the most likely diagnosis? It's a good example of a question where the answer is given within the question. Now, first of all, you should know peripheral vertigos like BPPV and all normally have that slightly torsional, nystagmus. So unlikely that this clear horizontal nystagmus agar idhar likha hai, I don't think they are indicating towards BPPV. Now what's happening towards the direction of nystagmus? Now normally the slow component is towards the affected side or towards the hypoactive side, and the fast is always the corrective component. Fast is the corrective component. It's like that. Okay, so the slow side direction is a direction where the problem is there. So here the slow component is towards the left side, so it basically means there is a left side hypoactive labyrinth. That is what it is indicating towards, and that would be the correct answer. Very straightforward answer. ये वाला क्वेश्चन पिछले INICET में आया था 2022 के, उसके पहले वाले INICET में भी आया था. arrange the order from cochlear nerve to hearing pathways. We've already done this. Simple. From cochlear nucleus, it goes to the superior olivatory nucleus. From superior olivatory nucleus, it goes to the lateral lemniscus. From lateral lemniscus, it goes to the superior colliculus, and superior colliculus to the medial geniculate body. So that would mean the option correct would be 1, 2, 3, and 1, 2, 4, 3 option. Yeah. Right. So this anyway we have already done, so I won't spend time. Identify the anatomical variant structure shown in the given image. Okay, again, this is an axial section of the CT scan. What are the structures? You can see the orbits here. You can see the black thing over here is the maxillary sinus on both sides. Big inferior turbinates you can see over here. Little bit chota middle turbinates can be seen here. And they are asking what is this abnormal structure over here, which is this round thing. Now remember, air is black on CT scan, so there is some air over there. Now let us just look at the other options. Okay, so now Haller cell, this is not, the arrow is not pointing towards the location of the Haller cell. How I remember Haller is Haller mein do L hain, and that L is how I remember it points to the lamina peparissia, which is this area over here. This is lamina peparissia के पास अगर कुछ होता है L लगने के चांस रहते हैं. यहाँ डबल L लगे हुए हैं. Haller, lamina peparissia. Onod sound like sphenoid, sphenoid, S-P-H-E-O-I-D, noid, nodi, nodi, noid. Sounds very similar. So this is usually in the sphenoidal area and will not be seen in this kind of sorry, this is the coronal section. Did I say axial in the beginning? Axial is like this. This is coronal, side view, sagittal. Okay, sorry about that. So this coronal section, you're not going to really see the sphenoid. In the axial section, you may see the sphenoid. Sagittal section, like this, you may see the sphenoid. Okay, you won't see it in the coronal section inside the sphenoid. Concha bullosa is the pneumatization of the middle turbinate. The middle terminates look fairly normal over here. This is the pneumatization of the superior turbinate. The uppermost turbinate, inside the turbinate there is an air pocket. That's a pneumatized superior turbinate, and that would be correct answer in this. Now, a 75-year-old lady presented to ENT clinic with 1-year history of progressive nasal obstruction. Obstruction is there. Along with, there is mucoid discharge, occasionally blood stained. A mass was seen on endoscopic examination as shown below. CT was done and shown below. What is the most likely diagnosis? Okay, so that is the scan that you can. So let me bring this up. Right, so now you can see the. Now if you look at the history, okay, age is 75 years old. दिमाग में जाता है that maybe we are talking about something malignant. Symptoms do not appear as aggressive as malignant over here, and that is a hint that we need to understand that just saying progressive nose block with mucoid, colorless, sticky discharge, and occasionally blood stained. Even if you look at juvenile nasopharyngeal angiopharma, it's not going to be occasionally adolescent, younger males, not exclusively but almost exclusively. Nasal angiofibroma can be seen in females as well. This is a question waiting to be asked क्योंकि कोई ना कोई क्वेश्चन आता है एंड आजकल इक्वालिटी का ज़माना है. सो males also adolescent females can also get juvenile nasal angiofibroma. When they do, the spread to the maxillary sinus is most common in them. तो ये क्वेश्चन कभी भी आ सकता है, अभी तक आया नहीं है, बट इट इज सिटिंग देयर समवेयर ऑन द फेंस विद हैपन. ये क्वेश्चन मैंने 2-3 जगह सबमिट किया है, अगर हो जाएगा किसी क्वेश्चन बैंक पूल में से आ जाएगा. ऑलराइट, so that is so it's unlikely that this is juvenile so other side of being 55 years old. Squamous cell carcinoma maxillary sinus, yeah, there is some growth maxillary sinus over here. It is but symptoms maxillary sinus squamous cell carcinoma is going to be more destructive. Look at the CT scan, doesn't appear to be extremely destructive. There is no bleeding, there is no symptoms would be more than mucoid discharge. Doesn't sound. Neuroblastoma occurs in the part, olfactory part, eyes come out. This appearance, especially in this image, is very characteristic of inverted papilloma, like the polyps are growing inwards, papillary growth inwards, and it is locally invasive, there's about 10 to 12% chance of it becoming malignant. But in the elderly, in maxillary area, fairly common to see inverted papilloma, and the symptoms are less aggressive. They can present like this stain, mucoid secretion. So here, clinically correlating with these images, I would say the answer is inverted papilloma. Child presented with bilateral external auditory canal atresia. The external auditory canal है ही नहीं. Okay, here external canal is हो गया है, अब narrow है, बंद है. Not use it. So what is the best hearing device to be used? You can't basically use hearing aids or kind of implants. So here you're going to use something called as bone anchored hearing aid. Bone anchored hearing aid does not come under the classification of implant because it's a hearing aid where only the titanium part is implanted within the bone and it's not going through the entire bony layer. So sometimes they may say which of the following is not an implant and put Baha as an option. Then you it and come out hoo instead of Baha. All right, it's a hearing aid. It is not an implant because the titanium it is just within the skull or just outside the skull. It's just the titanium it's like a screw that goes inside to hold this hearing aid in place so that there's bony vibration is vibrating the cochlea is giving the sound because bahar se mechanism nahi hai, but the cochlear mechanism to the auditory pathway is there. So most of the other things, because there is no outer part, doesn't make sense to put a cochlear implant and put an electrode inside because you're not basically perceiving those kind of sounds. So bone anchored hearing aid is much likely a problem. You don't need any amplification inside the cochlea. That's why cochlear implant would not be indicated or any of these prostheses would. Right. So that is here. Which of the following is not used in post-total laryngectomy rehabilitation? This is a bit of a confusing question. Now, laryngectomy, larynx nikal diya, are done. So, which of the following are not being used? This case would be supraglottic swallowing. Supraglottic swallowing is a swallowing technique taught to stroke patients where they are not able to control a lot of their palatal movements, and the supraglottic above the hyoid, those are patients are trained to swallow in a way that they do not aspirate into their airway. Not usually done post total laryngectomy because the larynx is closed and that outlet is created over here, so no much role in preventing food created over here. Now esophageal speech, times the voice, the sound, the air is pushed food pipe collected from your stomach into your mouth, and then you can move your mouth to speak. That is the speech. Or tracheoesophageal prosthesis, where the air that you exhale from your lung is then through a one-way valve pushed into the food pipe, so that then that air comes into the mouth and you can phonate. And polite yawning is also polite yawning is a rehabilitation for smell basically. Because in laryngectomy patients, no air is going up to the olfactory area and they're not able to smell. We're doing certain polite yawning to basically trying to get all the air towards the olfactory area and teaching the people to the patients to recover some of their lost smell, because if the smell is not there, a lot of the appetite or the food or consume goes away. Okay, it is related to that. Alright, so here supraglottic swallowing is not used post-total laryngectomy. Polite yawning to improve olfactory, this thing, our smell, our esophageal speech, and our tracheoesophageal prosthesis are the things that are done. Now, a girl underwent mastectomy for chronic suppurative otitis media in the right ear. 2 months post-surgery, she presented with complaints of fluctuating hearing loss, vertigo, tinnitus, and ear fullness. Findings disappear on keeping the right ear up. What is the most likely diagnosis? Okay, so this is fairly straightforward. You can see the options are such a way that if you're looking at mastoidectomy's complications, then automatically The option that will come up over here will be a perilymphatic fistulas and synechiae. These are common after surgery. Labyrinthitis is an inflammation, viral, could be bacterial. Vestibular schwannoma is a growth, a malignant growth, a tumor, and that is got nothing to do with the surgery pages. So a perilymphatic fistula is the one, because it's a fistula and it's perilymphatic, so it is increasing the pressure into the inner ear, and that's why you have ear fullness. So that's another two. When you keep the right ear up, the fullness becomes less, and because of gravity, and the lymphatic pressure comes down and becomes, disappear. All of these point towards perilymphatic fistula. Now, all of the following are major criteria for the diagnosis of allergic fungal rhinosinusitis, except this. Actually, all the options look somewhat correct. But here the clues, which is a major criteria. So of course, nasal polyposis is the major criteria. Heterogeneous appearance in the maxillary sinus. Some places appearing with white, black dots. Heterogenic appearance is a characteristic. In CT scan finding, and a positive fungal culture, of course, is a major criteria. Allergic mucin test is not a major criteria; it is a minor. So this would be correct. Identify the structures with arrow in the image given below. Now here you can see. Let me point out to you. The arrow is pointing here. This is the ethmoidal canal. This is in front of the orbit, superior and above. Optic canal, cribriform plate, and all are medial. Okay, and posterior ethmoidal canal is posterior. You can't see it in this section. And some who identified this, call it a nipple sign, called as a nipple sign, because the projections look like nippular projection. Word itself means projection, pointed projection, and that anterior ethmoidal canal projection on bilateral side on the 6-year-old male patient with recurrent swelling in the marked area. Okay, so the marked area over here, I think what the area underwent surgery. Next day morning, patient is mild bleeding from the oral cavity. Surgeon expects the bleeder to be from. Now look, tonsil surgery, generally any arterial bleed is not going to be mild, so it cannot be arteries. Paratonsillar vein is the most common vein that bleeds immediately tonsil. It is also not a minor, but it is not so major that arterial bleed very hard to control. Paratonsillar vein you can still control with a lot of questions and all of that. Paratonsillar vein is the right answer. This question is again a repeat. This was asked in the last INICET. It was asked, I think, 2 years before as well. Choose the procedure done in the following given image, and this is nasociliary block as explained to reduce certain types of headaches, because nasociliary is the branch of the trochlear nerve and have headache because trochlear nerve irritation, and by giving this block you can give this certain kind of localized headache. An anterior ethmoidal block, which is given more here in the dorsum, can be given to block the septum, especially in rhinoplasty surgery or septoplasty surgery. This is helpful. One block here, and then your greater palatine block side, palatine block is through the nose all the way in the back. So here it would be the nasociliary block. Repeat. This is a बहुत ही टेढ़ा हुआ question asked very indirectly. Now figure out what this is. A child presents to the OPD with complaints of recurrent infection. Child is falling ill again and again, having recurrent infections, has abnormal faces. Faces matlab face, not feces, other side of the face. And cleft palate, as a palate cleft. So there's some syndrome over here. Tostic sign, Trossius sign were positive. Which of the following structures is affected in this? Directly asking the diagnosis, asking which structure, and that too embryological structure is affected in this child. So first let's understand what does this child have. Now abnormal faces and cleft palate can be then many syndromes. acoustic sign is basically when you're tapping on the, you're hearing flickering over here, happening like that human, you know. And then there is a Trousseau sign where you the blood pressure, you cough and and then you have this carpopedal spasm because of a condition called as hypocalcemia. Hypocalcemic tetany basically causes this particular. Now, what is this syndrome? This syndrome is called as Gorge syndrome, and it's called as a catch-22 because there's an involvement of the 22nd chromosome. Catch is basically there are cardiac abnormalities. A is abnormal faces, is the thymus gland is hypoplasia of the thymus gland. C is cleft palate, H is hypocalcemia, and the 22nd chromosome. Okay? And this is usually a problem of the third and fourth pharyngeal pouches. So cleft, cleft is basically forming the canal. The first the arches are there which are following the structures, the muscle of the veins, arteries, those things. The inner lining is formed by the pouch. The third and fourth pouch is the one here. Only fourth pouch is given as an answer. So over here the fourth is basically between the fourth and sixth pouch. This part is the first, second, third, fourth pouch. So fourth pouch is a closed. Third pouch would have been better, but the third pouch is not. First and second pouches are. So here 4 would be the correct. Identify the deformity in the pic below. Okay, frog face deformity, horse face deformity, golden hair syndrome, and adenoid faces. This is characteristic of adenoid faces. Have adenoids from the age of 5 or 6 or they are not having normal breathing because of this abnormal breathing. The facial bone growth is normal, faster, some lesser, and you get this elongated face because of less oxygen, and ossification changes that occur, giving this long face. You see this gap over here in this child between and the upper lip. The high arched palate, the arch of the palate is very high, overcrowding of there, and this is a classical adenoid face. Okay, frog face deformity is pharyngeal. COVID enters brain through. All had some form of this dreaded pandemic. I think you all remember. And we've lost smell, and that's why the affinity of the COVID virus to the olfactory system through cribriform plate, fastest way it can enter into the brain, largely olfactory bulbs and sense of smell. COVID virus enters the brain largely option A, which would be cribriform. Now, which of the following may not be present in complicated hepatitis? So there is a middle ear infection. You can have Bisol's abscess. Bisol's abscess is basically your sternocleidomastoid muscle. Around it, if there is an abscess, Bisol's abscess, which mastoid bone, middle ear infection, and that abscess anterior border sternocleidomastoid, and you have this tender swelling over along with pills. Bisol's abscess. If the same thing goes towards the posterior belly of gastric muscle, then that is called Sitelli's. Italiano Stelli abscess. The Bisol abscess. Alright. Whereas the delta sign and Grisenger's sign are related to the lateral sinus thrombosis, again related to the mastoid visceral vein being blocked and causing this. So battle sign we know is a skull base fracture sign that occurs because of base of skull. Battle sign has nothing to do with that, is straightforward. Person of larynx, and which mark structure does not constitute the larynx. This is a very basic question Tingra type. The hyoid bone is not considered a part of the larynx. epiglottis, thyroid, and cricoid are the parts of the laryngeal framework. So here, thyroid bone, ये वाला, this is not a part of a larynx. All of the following are objective tests of hearing exam. Objective means that the patient manipulate or it by his or puts it there, you can measure it, and whatever it comes. Whereas subjective, you will need the patient's inputs, and the patient's inputs may be not always accurate based on समझ में आया, instruction समझ में आया कि नहीं, का mood हुआ कि नहीं. Like pure tone audiometry is a subjective test over here, because pure tone audiometry, you put the patient in a soundproof room, you give them sound through the bone and through ear, and you are basically testing thresholds. So you're saying that if the patient cannot hear below a particular point, they stop hearing, they have to lift the finger, and then there's someone plotting it on a graph. Feels too tired, does not understand the instruction, because you have to hear properly and hear the instruction properly. Sometimes they may not give you a very accurate answer. Is the skill of the audiologist, the experience of the audiologist to figure out, double check, cross check a couple of times, two things, and then put out a pure tone audiometry graph. But that is not an objective test, it's a subjective. Impedance audiometry, you're basically giving pressure inside the canal, and you're looking for clients when telling whether there is. Vera is like an ECG. It's taking electrical waves, measuring the electrical pathway going from when sound is stimulated from the cochlea all the way to the auditory cortex in the brain. Photoacoustic emissions, they're listening to sounds that are made inside the cochlea because of fluid inside the basilar membranes, outer inner hair cells. It can be spontaneous, or it can be evoked by giving some sort of transient bursts or clicks kind of sounds. So OAE is currently the gold standard screening test, and because you don't require the child to fall asleep. Place the probe, you get the waves, okay, chalo, ear mechanism is working. But after that also, if there's delay, then in child speech development, you do BERA, and then cochlear, or an auditory brainstem, or some other type of speech rehabilitation. But impedance audiometry is normally done when there are pressure changes that are expected, and pure tone audiometry generally for any can take in get there here. Kind of graphed, and you can kind of get a number or degree of mild and moderate hearing loss, air conduction type, or bone. There's a given X-ray for the frontal sinus. What view is this? Caldwell view, or is this Waters view, Pierre's view, or Race's? Right? What are these views? So this is basically a Caldwell view. This is occipitofrontal. Okay, that's why it's showing like a mirror image is right in front of you. Okay, that is given over here. That's why you can see this frontal sinus. Left side is a little bigger, right side is slightly hypoplastic. Waters view is occipitomental. Also, maxillary sinus. It's hard to see maxillary sinus because you're looking head on. You can see half of the maxillary sinus covered by the mandible. If you do this, you're able to see the purely as a cavity, but the mouth. Pierre's view, you can see the mouth. Thesis view is a lateral oblique view. Look at the optic canal and to look at the ethmoidal sinuses. All right, so this is Caldwell's. Now, as an endoscopic image of the nasal cavity, not many of you may be familiar with this, but you have to get used to images. Carrying this well on their images is so that you get a bit of an orientation. Left nasal cavity, right nasal cavity is this. Right, so this is the left nasal cavity. How do I know that? Because you can see septal spur, this nasal septal spur part, right? And here you can see superior turbinate, which is this arrow is pointing to turbinate process. All right, Here they're asking identify the structure where this arrow is being put, and that the inferior turbinate, fairly standard and straightforward question. Middle turbinate and uncinate process के बीच में is where you see fundibulum and hiatus simulare, where all this maxillary sinus, ethmoidal sinus drain over there. Not sinus drains directly from a little bit medial to turbinate. So you don't go lateral to. Yeah, we are doing FES, we break up the process, and we see the ethmoidal bulla behind, then we the ethmoidal bulla, largest ethmoidal bulla cell. We keep going from clear out all the disease, ensuring कि हम laminar pepraceae के ज़्यादा पास नहीं जा रहे हैं. Arrange TJ Odotra pathway in ascending order. Again, this question घूम फिर के research years back, almost every question there is some of the auditory pathway properly, and since we have done this twice, I think it is very straightforward that it has to be here. They are not giving cochlear nucleus or spiral ganglion, so starting point will be superior olivatory nucleus in the pons, so it has to be either A or B. Superior olivatory nucleus के बाद lateral lemniscus, then inferior colliculus, and then geniculate ganglion. So that in a very straightforward way makes it option A, right? So guys, thank you and all the best for your exams. See, in INICET, ENT generally comes in an integrated way, palsy integrated many times with other medicine. That the auditory pathway is definitely an important element, but otherwise just CT scan images, ear images is they are usually the common trend in INICET. 5-6 सवाल पूछे जाते हैं per year. Last 4 exams का करके भी there are hardly about 30 odd ENT questions that are being asked, but rest assured these are important questions, and with a specific focus on certain x-rays, scans, tests. Audiology से ज़्यादा आया नहीं है except for the auditory pathway and about the Baha implant and kind of thing. Usually give proton audiometry or tuning fork based. We have not seen the last 4-5 exams. So nothing to worry about from ENT standpoint. All the best, and once the exam is done, try our best to all the questions and give you a quick snapshot of. If you have any questions at any point of time, feel free to send me a DM. Question is yeah, put to ENT or put it in the comments after this live, and I will have questions or any demands for we created. Otherwise videos हमने बनाए हुए हैं. Best, take care, bye bye.